First of all, thank Dr. Mahapatra and Dr. Manoria for giving me this opportunity. My topic is slightly complicated, but I'll try to keep it simple. So we know that our earlier concept was that type 2 diabetes is produced by insulin resistance, which is working on muscles where there is reduced glucose uptake, and also on the liver where the glucose is constantly poured into the circulation. And this leads to hyperglycemia, and this also leads to an increased burden on the beta cells, which ultimately start getting to the exhaustion and death, and this leads to beta cell dysfunction also. But things have become more complicated. Now we know this differential hypothesis that there are multiple organs which are involved in pathogenesis of type 2 diabetes, and I'll be taking each one of them one by one. So coming to liver, see, liver is working as a buffer. After an overnight fast, liver produces approximately 2 milligram per kilogram body weight per minute of glucose, which it constantly pouring into the circulation in the fasting state. But in type 2 diabetes, this rate of basal hepatic glucose production is much increased. And this occurs in spite of 2 to 3-fold increase in fasting insulin levels. That means there is a severe degree of insulin resistance at hepatic level. High hepatic glucose production is also driven by glucagon, which remains high due to suppressed effect of incretin. We know that incretin hormones, they can suppress glucagon, but there is reduced incretin effect in type 2 diabetes. This leads to increased glucagon, and so his liver is pouring more and more glucose into circulation. And one reason by which liver becomes resistant to the insulin is that there is accumulation of fat or triglyceride into the hepatocytes, and which plays a major role in hepatic glucose insulin resistance. Now coming to muscles, we know that after the interaction of insulin receptor and insulin, there is a downstream changes in the cytoplasm, and this action of insulin in the downstream mechanisms is deranged in the myocytes. These include impaired glucose transport, decreased phosphorylation of certain enzymes, reduced glycogen synthesis, and decreased glucose oxidation in the muscles. Now, we know that adipokines and free fatty acids released from the fat cells regulate the insulin sensitivity in the muscles, and adiponectin, which is again released from the fat cells, improves the insulin sensitivity, while free fatty acids, TNF-alpha and interleukin-6, which are produced by the fat cells, decrease the sensitivity of insulin. Now coming to adipose tissue, now it is recognized that adipose tissues work as a big endocrine organ. Adipocyte, which is ballooned because of accumulation of fat, that is triglyceride, produces certain adipocytokines, and these are also pro-inflammatory products. These include resistin, visfatin, TNF-alpha, interleukin-6, and simultaneously there is also increased lipolysis, which is releasing a lot of free fatty acids into circulation. These products not only interfere with the insulin action in various tissues, but are also pro-atherogenic. The fat cells, which are devoid of triglyceride, that is fat, produce a hormone known as adiponectin, which increases insulin sensitivity and also anti-atherogenic. Now, this hormone plays a very important role in deciding the muscle insulin sensitivity. Now, we know that pioglitazone, which Dr. Panikar was just talking, has predominantly receptors present on the fat cells. But we also know that its major effect is on increasing the glucose uptake on the muscle. So it's very clear there is a crosstalk between the fat cells and the muscles, and anything which regulates the muscle insulin sensitivity, there's some products which coming from the fat cell which will decide whether muscle is insulin resistant or not. Now, we also know that free fatty acid flux from the adipose tissue is responsible for ectopic fat deposition in the liver and other organs. And we know that this is likely to produce the non-alcoholic fatty liver disease, NASH, and then this can subsequently worsen the insulin resistance in the liver. Now, coming to beta cell defect, persistent hyperglycemia puts a lot of burden on the beta cells to work harder and harder, leading to their apoptosis. By the time the type 2 diabetes is diagnosed, almost half the beta cell mass is already lost, while insulin resistance itself leads to glucose intolerance. beta cell dysfunction is required for development of the overt diabetes. Beta cell function increases in the early disease to compensate for insulin resistance and maintaining euglycemia, but very soon, eventually, the beta cells exhaust and their capacity to adapt to the demand posed by the insulin resistance decline, and this is how the patient's glucose, first the postprandial and the fasting, they start rising and patient becomes diabetic. Another very important fact is that there is also an incretin effect, and we can understand this, but by seeing these two cartoons on this, these two figures on this slide. Now, if you give a patient oral glucose, and then you can see, follow that in the venous blood, you can see there is a peak which occurring at 40 minutes, then it declines. And if you produce a similar type of peak by giving a glucose infusion IV, you can produce similar type of peak here. But the response of insulin, it is quite different. That is, the insulin produced by giving oral glucose is much, much higher than what is given at the same type of glucose value in the venous blood is much less. Now, till now, we were thinking that the greatest stimulus for beta cell to produce insulin is glucose, but now it's very clear that more than 60% of the stimulatory effect of beta cells come from these incretin hormones, and these are GLP-1 and GIP. And in diabetes, both these hormones are deficient, and then we know that there is an incretin defect here. And this particular mechanism of beta cell defect can be addressed by many therapies, which either can be GLP-1 receptor analogs, or which may be some drugs, oral drugs, which can prevent degradation of native GLP-1. Now, if you see in this particular slide, that after a glucose load given orally, you can see that in a normal person, this green graph shows that there is a very rapid increase. Within 5-10 minutes, there is a very rapid increase in insulin secretion in the circulation. And this, then there is a first peak, this is first phase insulin response, and then there is a blunted second peak, this is second. And if you see the glucagon on the other side, you can see that after oral glucose, there is a steep fall in glucose level, glucagon level. And if you match these green lines, you can see this graph is just mirror image of this. So there is this first phase of insulin response is very important, because this is acting in a paracrine way to adjoining alpha cells to suppress glucagon, and see what happens in type 2 diabetes. The first phase insulin response is almost completely gone in these orange lines, and the second peak is also blunted, and see what happens to glucagon. Glucagon remains high in spite of high glucose, which it should have been suppressed. So if you see the mechanism of this failure of glucagon, this is alpha cell which produces glucagon, and each alpha cell is juxtaposed with at least 2 beta cells. And when beta cells produce insulin, and the very first phase of insulin response is that it goes and suppresses the alpha cell to produce glucagon. There are other factors like GLP-1 receptor agonist, but remember, GLP-1 will come very late after the food has reached the terminal ileum. GLP-1 is produced and reaches the pancreas. So it will be late response, not the immediate response, which is seen by the first phase of insulin response. Glucose, when glucose enters the alpha cells, there is a suppression of glucagon. On the other side, adrenaline stimulates glucagon secretion. So it's very clear that the paracrine action of beta cells by producing first phase insulin response is very important in suppressing glucagon. So coming to abnormal glucose handling, type 2 diabetes, the renal threshold for glucose reabsorption is increased due to increased expression of SGLT2. Glycosuria works as a safety wall against the runaway hyperglycemia. So whenever the glucose levels are above 200, 300, there is a safety wall for the body to excrete the hyperglycemia and keeping the blood glucose not going beyond 300, 400. By downgrading the GLT2 action, we can offload the beta cells of hyperglycemia and restore their normal function. And this can be seen in this cartoon that normally we are excreting something like 160, 170 grams of glucose in glomerular filtrate, out of which 90% is reabsorbed back because of SGLT2, and nothing will come out. But if there is hyperglycemia, very significant glycosuria will occur, and it will not allow blood glucose to go beyond certain limits. Now, this is an animal experiment where the animals were given the, the glucose, and then their insulin on measured. So this is control, and this is diabetic, and this is first phase. This is absolutely down with the type 2 diabetes or any diabetes. But when these animals were given the glucose load along with this SGLT2 inhibitor, the first phase insulin response was almost completely restored weight. And this is also happening with the second phase insulin response in controls in diabetic animals, and then when it was given with the SGLT2 inhibitor. So this response was restored. So we can say that the glucotoxicity can one of the best addressed by giving SGLT2 inhibitors. Now coming to role of CNS, we know that there is a resistance and lack of anorectic effect of both incretin hormones as well as leptin. Brain regulates the amount.
Left, sir.
Okay. Brain regulates the amount and type of the food we consume, and energy storage and energy expenditure is also decided by the brain. Through the neural connection, it also regulates the insulin and counter-regulatory hormones. Efficient energy storage in the form of fat and its quick conversion into glucose was a survival advantage in evolutionary early years. But now this, with the available of abundance of food and lack of exercise, this particular survival advantage has become a curse for us. So in conclusion, I'll say that type 2 diabetes is multifactorial, multi-organ disease. Anti-diabetic medication should address underlying pathogenic mechanisms rather than solely reducing the blood glucose level. To achieve the durable HbA1c reduction, emphasis should be placed on medication that ameliorates insulin resistance and prevent beta cell failure. And this will usually require combination therapy in majority of type 2 diabetic patients. So thank you very much.